Laryngeal muscles. We classify the laryngeal muscles as intrinsic or extrinsic. The intrinsic muscles are used for phonation and/or vocal cord movement, while the extrinsic muscles are used to support the larynx inside the neck. The intrinsic muscles of the larynx. The true vocal cords attach anteriorly to the thyroid cartilage and posteriorly to the arytenoid cartilages. We can categorize the intrinsic laryngeal muscles according to their functions. See the table below. You must know the cricothyroid, the vocalis, the thyroarytenoid, the lateral cricoarytenoid, posterior cricoarytenoid, the thyroid cartilage, the arytenoid cartilage, the corniculate cartilage, the cricoid cartilage. The following adjust the length, meaning the tension of the vocal ligaments: the cricothyroid, the vocalis, the thyroarytenoid. The cricothyroid elongates, meaning it tenses, the vocalis shortens, meaning it relaxes, and the thyroarytenoid also shortens. The cricothyroid is innervated by the external branch of the superior laryngeal nerve, and the vocalis and thyroarytenoid muscle are innervated by the recurrent laryngeal nerve. The following either abducts or adducts the vocal folds, meaning it changes glottic diameter. The thyroarytenoid adducts the vocal cords, meaning it makes the glottis more narrow. And the lateral cricoarytenoid also adducts the vocal cords and makes the glottis more narrow. The posterior cricoarytenoid abducts the vocal cords, meaning it widens the glottis. All three of these are innervated by the recurrent laryngeal nerve. The area epiglottic and the interarytenoid control sphincter function. The area epiglottic closes the laryngeal vestibule and is innervated by the recurrent laryngeal nerve. The interarytenoid closes the posterior commissure of the glottis and is innervated by the recurrent laryngeal nerve. Note the thyroarytenoid serves two primary functions. If you see it in a matching question, match the other muscles first and then use the remaining answer choice for this muscle, assuming it's adduction or relaxation of the vocal cords. Sometimes you're just going to have to memorize things, but these mnemonics can help. Muscles that tense and relax the vocal cords. Remember, cricothyroid. C is cords, T is tense. So cricothyroid. The C in crico is cords, and the T in thyroid is tense. Thyroarytenoid. So the T in thyro is they, and then the R in arytenoid is relax. Muscles that abduct and adduct the vocal cords are the posterior cricoarytenoid. You can remember this by PCA, please come apart, and the lateral cricoarytenoid. Let's close airway. Extrinsic muscles of the larynx. The extrinsic muscles attach the larynx to the surrounding anatomy and allow for movement of the larynx within the neck. Breathing and swallowing, for example. The following elevate the larynx: the stylohyoid, the geniohyoid, the mylohyoid, the thyrohyoid, the digastric, and the stylopharyngeus. The following depress the larynx: the omohyoid, the sternohyoid, and the sternothyroid. Innervation of the upper airway. The innervation of the upper airway is extraordinarily complex. If you want to know all there is about the topic, you'll need to consult a primary text. This is just a cursory review. It's essential that you know the sensory innervation of the entire airway as well as the motor innervation of the larynx. Be sure you can apply this information to fiber optic intubation. Regarding the superior laryngeal nerve, this nerve branches off the vagus nerve just beyond the jugular foramen at the skull base. At the level of the hyoid, it divides into the internal and external branches. The internal branch penetrates the thyrohyoid membrane between the greater cornu of the hyoid bone. The external branch enters the cricothyroid muscle. Regarding the recurrent laryngeal nerve, this nerve is a branch off the vagus nerve inside the thorax. The right recurrent laryngeal nerve loops around or under the subclavian artery, so it loops under the subclavian artery, while the left recurrent laryngeal nerve loops under the aortic arch. After looping under these vascular structures, both nerves ascend the tracheoesophageal groove to join the larynx. Due to its location in the thorax, the left recurrent laryngeal nerve is more susceptible to injury. The following table reviews the sensory innervation of the airway. The trigeminal nerve, cranial nerve 5, is broken up into 3 nerves. V1 is ophthalmic, V2 is maxillary, and V3 is mandibular. V1 ophthalmic is anterior ethmoidal. It innervates the nares in the anterior one-third of the septum. V2 is maxillary, which is sphenopalatine, and innervates the turbinates and septum. V3 is mandibular or lingual, and it innervates the anterior two-thirds of the tongue. The glossopharyngeal nerve, cranial nerve 9, innervates the soft palate, the oropharynx, the tonsils, the posterior one-third of the tongue, the vallecula, and the anterior side of the epiglottis. It's also important to know that this is the afferent limb of the gag reflex. The superior laryngeal nerve has an external and internal branch. The external branch has 0 innervation of sensory function, and the internal branch innervates the posterior side of the epiglottis at the level of the vocal cords. The true vocal cords are ligaments, and they are not innervated. The recurrent laryngeal nerve innervates below the vocal cords all the way to the trachea. Regarding motor innervation, the superior laryngeal nerve external branch innervates the cricothyroid muscles, which tense the vocal cords. The internal branch does have motor innervation of the larynx. So there is no motor innervation with the internal branch of the superior laryngeal nerve. The recurrent laryngeal nerve innervates all intrinsic muscles of the larynx except the cricothyroid. Clinical presentation of a laryngeal nerve injury. The superior laryngeal nerve external branch innervates the cricothyroid muscle. This muscle is thought to be the tuning fork for the voice. Injury to the trunk of the superior laryngeal nerve or the external branch causes hoarseness because the vocal cords cannot be tensed. Regarding recurrent laryngeal nerve injury, you must know the difference between the unilateral and bilateral injury as well as acute versus chronic injury. You must also know which conditions require emergent airway management. A unilateral injury results in the paralysis of the ipsilateral vocal cord abductors. This does not cause respiratory distress. Acute bilateral injury results in bilateral paralysis of the vocal cord abductors. This favors a dangerous situation where tensing the action of the cricothyroid muscles act unopposed. Therefore, the patient with an acute injury to both recurrent laryngeal nerves is at risk for stridor and respiratory distress. This patient requires intubation or a surgical airway. Chronic injury is well tolerated and does not cause respiratory distress. The following table lists recurrent laryngeal nerve injuries on left side or on either side. So, injury on either side can be caused by external pressure from the endotracheal tube, external pressure from the LMA, thyroid surgery, parathyroid surgery, neck stretching, or tumor. However, a recurrent laryngeal nerve injury on the left side only can be caused by PDA ligation, left atrial enlargement, such as what happens with mitral stenosis, aortic arch aneurysm, and thoracic tumors. There are 3 infiltration airway blocks that you should know: glossopharyngeal, superior laryngeal, and transtracheal. Regarding the glossopharyngeal block, the needle is inserted at the base of the palatal glossal arch, which is the anterior tonsillar pillar, at a depth of 0.25 to 0.5 centimeters. Aspiration of air means that the needle is too deep. Aspiration of blood means that the needle should be withdrawn and redirected medially. The carotid artery is very close to this area, so if you aspirate blood, redirect the needle medially. First, withdraw it. After correct positioning, 1 to 2 mils of local anesthetic is injected on both sides. there's a 5% incidence of intracarotid injection. This puts patients at risk of seizure. Regarding the superior laryngeal block, anesthetic is injected at the inferior border of the greater cornu of the hyoid bone. 1 ml is injected above the thyrohyoid membrane, and then 2 mL is injected 2 to 3 millimeters beneath the thyrohyoid membrane. Aspiration of air means that the needle is too deep. You're in the trachea. Regarding the transtracheal block, the needle is advanced in a caudal direction as it penetrates the cricothyroid membrane. After aspiration and before injection, the patient should take a deep breath. During that inspiration, 3 to 5 mL of local anesthetic is injected into the tracheal lumen. The patient will cough, spraying the local anesthetic up through the cords. Laryngeal anatomy. The adult larynx extends from C3 to C6. It consists of bone, ligaments, and 9 cartilage. 3 cartilages are paired and 3 cartilages are unpaired. The anterior ligaments. The thyrohyoid ligament, the cricothyroid ligament. Unpaired cartilages. The epiglottis, the thyroid cartilage, and the cricoid cartilage. Paired cartilage. The corniculate, the arytenoid, and the cuneiform. The hyoid bone is the only bone in the body that does not articulate with another bone. It forms the main support of the larynx and attaches to the thyroid cartilage via the thyrohyoid ligament. Regarding anterior ligaments, the thyrohyoid membrane attaches to the larynx, specifically to the thyroid cartilage, and it attaches the larynx to the hyoid bone. The cricothyroid membrane. It attaches the cricoid and thyroid cartilages. This is punctured during a cricothyrotomy to emergently secure the airway. The needle for a transtracheal block is placed here. When the patient coughs, the local anesthetic is pushed cephalad and anesthetizes the vocal cords. Regarding paired cartilages, the corniculate and cuneiform cartilages provide support or structure to the aryepiglottic folds. The cuneiform cartilages are lateral to the corniculate. These sets of cartilages often appear as bumps on the aryepiglottic fold. They are often incorrectly identified as the arytenoids during direct laryngoscopy. You cannot see the arytenoids during direct laryngoscopy. The arytenoid cartilages are shaped like 3-sided pyramids. The base of each arytenoid articulates with the cricoid cartilage to form a ball and socket joint that allows the arytenoid to rotate, pivot, and glide. This allows the necessary movement for vocal cords to function. Like any other synovial joint, the movement of the arytenoids can be significantly restricted by rheumatoid arthritis and systemic lupus erythematosus. Airway obstruction may occur. The following diagram lists the structures surrounding the vocal cords. Regarding unpaired cartilages, the epiglottis, the thyroid, and the cricoid. The epiglottis provides a mechanical barrier between the pharynx and laryngeal opening. The vallecula is the space between the base of the tongue and the anterior side of the epiglottis. The thyroepiglottic ligament connects the epiglottis to the thyroid cartilage. Thyroid. The thyroid cartilage provides structure and protection to the larynx. It is the largest cartilage in the larynx. It forms the Adam's apple, which is more prominent in men after puberty. Cricoid cartilage is the most caudal part of the larynx. Also, it is the only complete cartilaginous ring in the airway. So what is the narrowest part of the pediatric airway? There's some controversy about this. In the anesthetized child, the most current evidence suggests that the vocal cords are the narrowest region of the pediatric airway. Having said this, the vocal cords are soft structures that will stretch as an endotracheal tube is placed between them. Classic teaching suggests that the cricoid ring is the narrowest part of the airway. This is partially true, because we can displace the vocal cords with an endotracheal tube, meaning it's a dynamic space. However, the diameter of the cricoid at the base of the funnel can't be increased. It can, however, be reduced by edema that results from endotracheal tube ring that's too large. Multiple intubation attempts, prolonged intubation, and frequent head positioning all can produce edema around the area of the cricoid ring. So in the adult airway, the laryngeal shape is a cylinder. In the pediatric airway, it's a funnel. In the adult airway, the narrowest region is definitely the vocal cords, whereas in the pediatric airway, the vocal cords are the most narrow, but they're dynamic. The cricoid is the most narrow, fixed anatomy. So having read all the textbooks and the NBC RNA bibliography, we found a pretty even split. Some say vocal cords, others say cricoid. You'll also find conflicting answers between chapters in the same book. A well-written test question about this topic should provide context to guide you to the best answer. A laryngospasm is the sustained and involuntary contraction of the laryngeal muscles. This results in the inability to ventilate. This response often outlasts the stimulus, and it may result in a complete airway obstruction, negative pressure pulmonary edema, gastric aspiration, cardiac arrest, and death. It is more common in children, especially less than 1 year of age. Risk factors for laryngospasm include pre-anesthetic concerns such as an active or recent upper respiratory tract infection, meaning less than 2 weeks, exposure to secondhand smoke, reactive airway disease, GERD, and age less than 1 year. Inside the OR, so perioperative or intraoperative, risk factors for laryngospasm include light anesthesia, particularly with concurrent airway manipulation, saliva or blood in the upper airway, hyperventilation, hypocapnia, surgical procedures involving the airway such as tonsillectomy, adenoidectomy, nasal or sinus surgery, laryngoscopy, and bronchoscopy, or palatal surgeries. The reflex pathway of laryngospasm involved the afferent limb, which is the superior laryngeal nerve internal branch, and the efferent limb, which is the superior laryngeal nerve external branch, and the recurrent laryngeal nerve. Tensing of the vocal cords is a byproduct of the cricothyroid muscle. Adduction of the vocal cords is a byproduct of the lateral cricoarytenoid and thyroarytenoid. Signs of laryngospasm include inspiratory stridor, suprasternal and supraclavicular retractions during inspiration, a rocking horse appearance of the chest wall, increased diaphragmatic excursion, and lower rib flailing. Factors that reduce the likelihood of laryngospasm include avoidance of airway manipulation during light anesthesia, CPAP 5 to 10 centimeters of water during inhalation and induction, as well as immediately post-extubation, removing pharyngeal secretions and blood before extubation, tracheal extubation when deeply anesthetized or fully awake, not in between, laryngeal lidocaine, duration lasts about 30 minutes, IV lidocaine before extubation, hypercapnia, hypoventilation, and PaO2 less than 50 millimeters of mercury. All of these reduce the likelihood of laryngospasm. Regarding treatment, it's almost as though nature embedded a fail-safe mechanism where hypercapnia and hypoxemia tend to break laryngospasm. We do not recommend that you wait for nature to take its course. Instead, laryngospasm should be treated with the following interventions: 100% FiO2, remove noxious stimuli, deepen the anesthesia by increasing the concentration of inhalation agent or even with a small dose of propofol or lidocaine. CPAP, 15 to 20 centimeters of water while instituting maneuvers that open the airway, such as the head extension, chin lift, and Larson's maneuver. If IV access is available, you can use succinylcholine 2 milligrams per kilogram in neonates and infants or 1 milligram per kilogram in children and adults. For completeness, you may see a range of 0.1 to 1 milligram per kilogram in the text. If no IV access, succinylcholine 5 milligrams per kilogram in a neonate or infant or 4 milligrams per kilogram in a children or adult. Submental administration will produce the fastest onset. In children less than 5 years old, they should receive atropine 0.02 milligrams per kilogram with succinylcholine to prevent bradycardia. Regarding the Larson's maneuver, also called the laryngospasm notch, first, we'd like to point out the Larson's maneuver is not simply a jaw thrust. The Larson's maneuver is the application of firm pressure to laryngospasm notch, located behind the earlobe. Pressure is applied bilaterally towards the skull base. This accomplishes two goals. It displaces the mandibular bone anteriorly to help open the airway, and it often breaks laryngospasm, causing the lightly anesthetized patient to sigh. Pressure should be applied for 3 to 5 seconds and then released to 5 to 10 seconds. Repeat until relief of laryngospasm. Other airway maneuvers to know: the Valsalva maneuver is exhalation against a closed glottis or obstruction. The risk is increased pressure in the thorax, abdomen, and brain. Muller's maneuver is inhalation against a closed glottis or obstruction. The risk is subatmospheric pressure in the thorax and negative pressure pulmonary edema. Upper airway anatomy. The upper airway extends from the mouth and nares to the cricoid cartilage. The primary functions of the upper airway include warming and humidifying inspired air, filtering particulate matter, and preventing aspiration. When the patient is intubated, bypassing the function of the upper airway, a heat and moisture exchanger, or HME, warms and humidifies inspired air, while the cuff of the endotracheal tube protects against aspiration. As you look at this image, see if you can recall the sensory innervation of the upper airway. Upper airway patency. During normal inspiration, diaphragmatic contraction and chest wall expansion create a negative pressure to draw air into the lungs. What you should appreciate is that the upper airway is also subjected to this negative pressure. In consequence, there is a tendency for soft tissue in the upper airway to collapse during anesthesia. You can think of the pharynx as a collapsible tube that lives inside a box. This box is formed by the borders of the surrounding anatomy, such as the tongue, soft palate, pharyngeal tissue, and cervical spine. The bone remains in a relatively fixed location. However, the position of the soft tissue is dynamic throughout the inspiratory cycle. Factors that impair airway patency. Conditions that reduce the diameter of the tube include reduced pharyngeal dilator muscle tone, negative pressure breathing during inspiration, or negative pressure during inspiration. And conditions that reduce the size of the box include increased soft tissue inside the box, such as obesity, macroglossia or enlarged tongue, hypertrophy of the tonsils and or adenoids, and a decreased size of the box can be a result of small craniofacial structures or craniofacial deformity. Upper airway obstruction. In the awake state, airway obstruction is prevented by 3 sets of dilator muscles. There are 2 competing explanations for the primary cause of upper airway obstruction during anesthesia and sedation. Number 1 is the tongue obstructs the airway. The genioglossus muscle relaxes and allows the tongue to obstruct the airway. Number 2 is the soft palate obstructs the airway. The tensor palatine muscle relaxes and allows the soft palate to obstruct the airway. The following are the 3 pharyngeal dilators: the tensor palatine, which opens the nasopharynx, the genioglossus, which opens the oropharynx, and the hyoid muscles, which open the hypopharynx. Lower airway. The trachea begins at C6 and it ends around T4 or T5, which is the level of the carina. It's 2.5 centimeters wide and it's 10 to 13 centimeters long. It contains semi-circulated rings that open posteriorly and ciliated columnar epithelium. Sensory innervation is via the vagus nerve, and blood supply is inferior thyroid artery, superior thyroid artery, bronchial artery, and internal thoracic artery. Again, the carina is about the level of T4 to T5, and it corresponds with the angle Louis. It contains ciliated columnar epithelium as well. Alveoli are about 300 in count, 300 million by the age of 9. They consist of squamous epithelium and have pores of Kohn that allow air movement between alveoli. Pneumocytes. Type 1 cells provide surface for gas exchange. They are flat squamous cells and they cover about 80% of alveolar surface. They form tight junctions. Type 2 cells produce surfactant. They're cuboidal cells, and they're resistant to oxygen toxicity. They're capable of cell division and can produce type 1 cells. Type 3 cells are macrophages. They fight lung infection and produce inflammatory responses. Neutrophils are present in the alveoli in smokers and patients with acute lung injury. The mainstem bronchi. The right is about 2.5 centimeters long, and it's at a 25-degree takeoff from the trachea. The left mainstem bronchi is 5 centimeters long, and it's about a 45-degree takeoff from the trachea. The mainstem bronchi consist of cuboidal epithelium. A few key points. In the textbook patient, the distance from the incisors to the larynx is about 13 centimeters, and the distance from the larynx to the carina is about 13 centimeters. Therefore, the distance from the incisors to the carina is about 26 centimeters. Keep in mind that there is variability to these numbers. Neck flexion makes this distance shorter, while neck extension increases this distance. The tube goes where the nose goes is an easy way to remember this. The right bronchus is 2.5 centimeters in length and projects about 25 degrees from the long axis of the trachea, while the left bronchus is 5 centimeters in length and takes off at about 45 degrees from the trachea. This explains the greater likelihood that the right mainstem intubation for a right mainstem intubation to happen, as well as aspiration of foreign body to enter the right bronchus. In children up to 3 years of age, both bronchi take off at about 55 degrees from the long axis of the trachea. Characteristics of progressive airway division. The following increases as the airways bifurcate. The number of airways increases, the cross-sectional area increases, and the muscular layers increase. The following decreases as the airway bifurcates. Airflow velocity decreases, the amount of cartilage decreases, goblet cells decrease, and these goblet cells that are more superior or proximal in the airway are responsible for mucus production, so those are decreasing as you're bifurcating along distally down the airway. And ciliated cells also decreases as the airway bifurcates, and these are responsible for clearing mucus.